I am. I think we're going to go ahead and get started. It's 3 after.
Okay.
So welcome everybody and thank you so much for joining. We have a couple of guests tonight. Our star guest is Kim Saruwatari, who's the public health officer for the county of Riverside, who is naturally a very busy woman these days, so there's lots going on. So we really appreciate her taking the time to join us. And welcome and take it away. Let me know if you want to screen share or we're just going to talk.
Okay, great. Thank you. And Jeff, actually, just a correction. So I am the public health director for the county. And then also with me tonight is Dr. Cameron Kaiser, and he is the public health officer.
Excellent.
So,
okay.
Yes. So I appreciate it, but I'm just the director. So I think Dr. Kaiser was going to start, if that's okay, and then I'll fill in the gaps after he talks.
Excellent.
Great. Dr. Kaiser, I'll turn it over to you.
Thanks. I'll just give a couple of brief remarks because there's certainly a lot of questions about the vaccination rollout and particularly how it applies to people living with HIV. And I think that the best that I can say is that we, as the health officer of the state, are pointing out to the state decision makers that people with HIV should be considered to have a chronic condition that predisposes them to more severe disease and treated in that light. Even if your CD4 count is good and your viral count is low, there are likely to be other medical or socioeconomic associations that mean you are more likely to have a worse outcome. That said, one thing I'm not going to do is sandbag the state on this call. They have the terrible and unenviable task of figuring out who's going to get shafted with the limited amount of vaccine that's on offer. For better or worse, they have chosen to centralize that decision, and pretty much everybody is angry with them as a result. There are also lots of politics that are going both ways, and I'll just simply leave it at that. Just know that we are advocating for the HIV positive community as we would for anyone with any chronic illness that would predispose them regardless of their age. I will say, however, that I have not seen any study that indicates that people living with HIV are more likely than anybody else to have an adverse reaction to the Pfizer and Moderna shots. And it is probable that you will observe the same benefits as somebody who does not have HIV. Naturally, that benefit is, of course, greatest if your CD4 count is not suppressed and your viral load is. And if you are within the priority age ranges and you are a person living with HIV, as far as I'm concerned, from a medical perspective, I would not hesitate to get vaccinated under those circumstances. I know that there's going to be a lot more to be said in the future about how exactly the state plans to do that. I imagine some of you have gotten your first dose already. And the county is reaching out to you about the second dose. And I think that's a good segue into what Kim will be talking about, which is the actual mechanics of the vaccine rollout.
Great. Thank you, Dr. Kaiser. So just to kind of highlight at a high level, you probably all have been following along in terms of vaccine rollout. Our biggest, our limiting factor at this point is simply the availability of vaccine. So we are currently getting into the county less than 23,000 doses of vaccine per week. And when we look at the state's tiers and phases, we know that in phase 1A, which was all of the medical providers, our promotoras, our laboratory workers, and our EMTs and paramedics, there are about 110,000 individuals. When we drop that down to include persons 65 and older, farm workers or agriculture community, teachers, and emergency services, which are the eligible populations at this point, according to the state's guidelines, we're looking at about 800,000 people that are currently eligible for vaccine. So when you couple that with very limited vaccine supply coming in, that's where we get into having to make these tough decisions that Dr. Kaiser was outlining in terms of how do we prioritize and not only how do we prioritize based on risk, but also based on equity, so that we're looking at those populations that are disproportionately impacted by COVID. To give you an idea of kind of the amount and scope of vaccination efforts in the county right now, we've received about 204,375 doses of vaccine into the county total. And that is vaccine that's used both by the county health department, but also has been distributed to all of the providers or to approved providers, which I'll get into in just a second. Of that 204,000, So far, 184,257 doses have been administered or put into somebody's arms. And so we're looking at about 87% that has already been administered. So actually really great work on the part of all the providers to get vaccine into people's arms quickly once they receive vaccine. We have, in order to be a provider and to administer the COVID-19 vaccine, you have to be approved by the state of California. And so we currently have about 200 providers that have gone through that process and are approved to administer the COVID-19 vaccine. And so in that process, the state looks at confirmation of the ability to handle vaccine, to store vaccine. If it's Pfizer, then you have to have the ultra low temperature storage and all of those very specific requirements. So the state reviews that, make sure that you meet all of those requirements, but also make sure that you have the ability to enter the data into the California Immunization Registry, or CARE. So CARE is a statewide database. There are a few exceptions. San Diego and LA have a different database, but CARE is where we pull data from, and the state pulls data to look at administration rates, to look at demographics of those being vaccinated, and put together their information to roll up and pass on to the federal government. So of the 200 that have been approved, give or take, about 160 of them have received vaccine throughout the county. And some of them, it's a very small amount of vaccine because, again, we have very limited supply that's coming in right now. So we are hopeful that we will get more vaccine. I mean, the Biden administration has made their announcement about purchasing additional vaccine. The state has said that they are encouraged in talks with the CDC that the allocations will start to increase. But we actually have not seen that yet. At one point, we were getting between 30 and 40,000 doses a week. And now for the last couple of weeks, as I mentioned, we're down to about 23,000. Let's see what else. We have sites set up. We are looking at both fixed sites as well as mobile sites. So our fixed sites, we have sites set up at high schools. So Heritage High School in Menifee, we have Paris, we have Corona High School, Indio Fairgrounds, San Gorgonio Middle School. We are Tahquitz has recently been brought online. We are looking to add Palm Springs Convention Center. And we actually have a whole board of places that we would like to add sites once we get additional vaccine. We also are looking at mobile sites. So the advantage to mobile sites is we can go into, just as we did with testing, we partner with our community-based organizations and go into those communities that are unlikely to be able to get to one of our mass vaccination clinics or to their own providers for a variety of reasons, whether that's, they work during the workday and can't take time off, they don't have transportation, they don't have providers, going to a government clinic is not a reasonable alternative for them. So we want to have the ability to go into those communities and do vaccination clinics. So an example of that would be yesterday we were out at Tudor Ranch in Mecca, and we vaccinated about 257 farm workers. And so we were able to do that with our mobile team. So we currently have one mobile team right now. We're hoping to ramp up to 3 mobile teams and potentially more. But again, vaccine is our limiting factor. We also are carefully looking at equity. And so you may have heard me speak in the past, or Dr. Kaiser, about equity measures that the state had for testing. And so we use something called the Healthy Places Index. I know Kevin's familiar with it. And so it looks at a lot of different, there are about 25 or so factors that are taken into consideration as to whether or not a community is healthy. So it looks at access to healthcare, it looks at poverty, it looks at demographics, it looks at transportation, tree canopies, a variety of different things. And it lumps these census tracts into quartiles. So the highest quartile are those that are the most advantaged, so have the best health index. And then the lowest quartile are our most disadvantaged community members. So those that have higher rates of comorbidities and higher rates of death and shorter life expectancy. And so we use those quartiles when we're looking at equity. We did it with testing, and now we're doing it with vaccination. And so if we look at a comparison of our highest quartiles, so our most advantaged communities, to our lowest quartiles, our most disadvantaged communities, we really want to be getting vaccine into that lowest quartile. Right now, we are disproportionately vaccinating in the higher quartile. Now, some of that is because phase 1A was largely medical providers, and so that will skew the data and will skew it towards more affluent communities. So that's something that we're watching very carefully and want to make sure that we are going the extra mile to make sure that we're getting vaccine into those communities that are most in need. The other thing that I wanted to mention are second doses. Lots of discussion, I know, about second doses. And Kevin, thank you for your email about that. I appreciate that. Kevin asked some great questions about second doses. So where we are with second doses is basically since the beginning of the vaccination effort, we've had a lot of inconsistent messaging around second doses. And so that's been from the federal, the state, and the local level. And so I think that initially we were hearing that, okay, we're going to have plenty of second doses. Go ahead and get all your first doses out. Second doses will come in a separate order. Everybody will be fine. Everybody will be happy, get their second doses. Then we heard, you know what, we really need to get first doses into the arms of people. So go ahead and take your allocations for second doses and get them into people's arms. And then we, and it's kind of teetered back and forth between those two strategies. So there are a few different kind of thought processes, and Dr. Kaiser, jump in here if you want to add anything. There are those that think that it's very important to get the second dose within a certain time frame. So Pfizer's 21 days is what was approved in the EUA. Moderna's 28 days. The CDC has recently come out with a statement that says you can get it up to 6 weeks, right? Try to stick to the schedule, but you can get it up to 6 weeks. That 6 weeks is really based on available data, right? We're in a new vaccine period. And so we don't have years worth of data to say how far out you can get the vaccine and have it be effective. There are also those that are advocating, and it's been rather loud at the national level lately, that we should concentrate on first doses because you get some level of protection from both vaccines through just one dose. And with Johnson & Johnson coming out, hopefully, maybe in the March timeframe, March or April, and they're a one dose, even though the efficacy is less than Moderna and Pfizer with 2 doses, it still provides a level of protection. So the debate rages on in terms of which is the best strategy. What I can tell you right now is that our position as a county is we are going to continue with second doses. We have 5 second dose clinics set up for this week, 1 Monday, and we will continue to set up second dose clinics based on vaccine availability. So we are going to try to do it as close as possible to 21 or 28 days, but it's not going to be possible in every situation. As you can imagine, again, with 23,000 doses coming in a week, we either are going to be dedicating all of our vaccine to second doses, or we are going to spread out second doses a little bit more and try to continue to get first doses in arms. And so the latter is what we're working on right now. But again, I think that the federal government will probably be putting out some additional guidance in the not too distant future about that. Dr. Kaiser, anything you would like to add about that?
I'll just say that the studies for the vaccines were based on a 2-dose series, and I think we'd want to hew as closely to those as possible. We do have a mantra in vaccination that you don't restart a series. It's whenever I do the vaccination updates every year, we always say that in groups because generally it is not at all necessary. Let's say that you had years and years between one vaccine and another. I got my hepatitis A first vaccine while we had an outbreak, and then to my private shame, I let that lapse for several months before getting my next one, well past the time when the second one was due. But the nice thing about the hepatitis A vaccine in particular is the first one is usually very effective, and there's no reason to give me the first one again. You just go get your second. We believe that the same principle applies to messenger RNA vaccines like the Pfizer vaccine and the Moderna candidate, but we don't know that for certain. It is a very new technology. And I think that we as a county would like to hew as closely to what has been studied, as opposed to going out on a limb and hope that it all works out. It probably will work out. And if there is a delay between the doses, I think that the CDC's recommendation is sound with the evidence that we have. But I also think that even though there's a lot of thought that the first dose alone on getting as many of those into arms as possible and damn the torpedoes on the second dose, my only worry about that is we don't really know how effective that first dose is between them. We believe it's pretty good, but we really don't know that. And if you put evolutionary pressure on a virus, the virus will evolve. And if all this talk about reinfections with these new strains, the same applies to whatever antibody you have, whether it's from a vaccine or from natural occurrent sources. So as Ms. Saruwatari pointed out, the county policy is let's try to go for 2 and try to get in the time frame we can, and get as close to that as possible within the limits of the vaccine we have available.
Thanks, Dr. Kaiser. The only other thing that I would mention is just that we are trying to track some of the mutations that you're hearing about. Dr. Kaiser recently agreed to do some of the genomic sequencing. Dr. Kaiser, you want to mention that?
We're tracking a number of different kinds of strains with COVID-19, and I won't go into gross detail because there's actually, literally hundreds of them probably, and most of them have little or no clinical relevance. But we are particularly paying attention to the ones that show mutations within the spike protein, because those are the ones that have the biggest ramifications as far as communicability and the potential for escaping either natural or induced immunity, since most of these are targeting the spike protein specifically. This is one advantage of the mRNA technology, in that if it makes a change, you just make an analogous change in the vaccine, you start issuing it. But that kind of thing doesn't turn on a dime. You still have to get this back into production. You produce it the same way, but given that the volumes that have come out have not been impressive, it makes me wonder exactly how nimble that process would be if we ever had to do it. The idea with whole genome sequencing is that we send it out and we get an idea of what's there and try to compare it with other strains. This not only gives you an advantage as far as determining where a particular infection may have come from, which in countries with much smaller prevalences like Australia, New Zealand, Taiwan, stuff like that, those countries have actually been able to do it to supplement their contact tracing. This doesn't really fly in the US, where in our jurisdiction alone, we're adding 1,000 cases a day in some situations. But we still can at least sample some number of them and determine what strain is predominant, and based on that, help to give some predictions. Now, what does that boil down to as far as what folks need to do on the ground? Not a lot different. You're still going to be wearing facial coverings. You're still going to be social distancing. You're still going to be maintaining hygiene. What works for that works for a whole bunch of things, regardless of the particular strain. But nevertheless, we do want to have some sort of early warning system, because if we get in a situation where we do need to think about what impact a particular strain has on a vaccine rollout, we want to know about this problem sooner rather than later.
Great, thanks, Dr. Kaiser. So Jeff, I think that's all we have in terms of kind of prepared remarks, but happy to answer questions, or at least attempt to.
Great, thank you. So given, we've got almost 40 people on the call, if you could please type your questions into the chat, and we'll take them that way. That'd be a lot simpler than unmuting. So go ahead and I'll monitor the chat box here. And so, Dr. Kaiser, you mentioned, that people with HIV are expected to respond as well to the vaccine as anyone else. There have been a couple of papers coming out lately, one from the Lancet in UK about people with HIV there, as well as a article from Raj Gandhi at Harvard a couple of days ago, suggesting that people may be at somewhat higher risk if they have HIV. It's not a huge difference, but there are signs that, and is that playing in, is that kind of information being evaluated at the state level? And are they looking to kind of take that information and act on it? Or are they just going to commit to what they've got, and given the logistics of getting everything out in time?
Well, I will say that the state thought is, they're really looking at age first. And I think that there are a number of drawbacks to that, but the point can be made that it does seem that of the risk factors that are presently known, that seems to have the greatest correlation. That being said, I think that everyone on this call will agree that the population of people living with HIV is not monolithic. There are people in various states, not just in terms of their individual viral and clinical indices, but in terms of their other chronic diseases they have, which are unrelated to HIV. And we certainly talk about the equity question, but people with HIV have also struggled with their own equity concerns, as I'm sure that most of the people on this call will attest. The long and short of it is I don't want to speak ill of the state. As I mentioned, they have a terrible decision in front of them. A lot of this is being driven by political considerations above their level, and I think that most people on this call can think about what those are. But we do certainly want to make sure that everybody is advocated for, to the extent that the ultimate goal is to get everybody vaccinated. And I think that the point should be made clearly to the state, and we are making it, that the HIV population, the people living with HIV population, should be still considered in any rollout as any other chronic disease should be.
Thank you. So the first question in the box is, if you've already tested positive for COVID, should you wait 90 days after the last symptoms before getting the vaccine?
I haven't seen anything reliably that indicates that what the cooling off period should be. I believe we were using a 14-day period, which is pretty much as good as any. If you're going to pull a number out of thin air, 14 days sounds good. But as far as whether that has any, let's say you get it 7 days after and you didn't know, is that going to make a difference? Probably not. And if you wait 90 days, is that going to make a difference? Probably not either. But that's generally the rule of thumb we've worked on. That actually brings up the related question, and there was actually an article in the New York Times about this, is should people who have had COVID-19 before, is one shot enough for those people? We don't know that, and I'm not, I've said this point before, I'm not going to rely on natural herd immunity for COVID-19 because I don't know how good it is. I don't know how long it lasts. And now that we have this question about whether the strains may be causing problem for the vaccine, well, in this case, antibodies are antibodies, so why wouldn't we think the strains would cause a problem for people who've had COVID-19 before as well? Mm-hmm. For that reason, I don't think I'd rely on that. You may expect that you may have more your whatever side effects you might get from the vaccine, and I generally liken them to flu shot-like, may be a little bit more acute for you if you've had COVID-19 before. But as far as a cooling off period, the 14 days is pretty much selected out of convention. I have not seen any data that says there is any good time or not good time, other than the general rule that you probably shouldn't get a shot while you're acutely ill.
Great, thank you. And someone asked about hearing about the captive gorillas that have come down with COVID. That was at the San Diego Zoo, I believe. And are they trying to incorporate this into research?
Well, I'm sure the gorillas are very interested in that. But there were some early questions about how easily COVID-19 can spread in animal populations. For example, it does appear that felids, such as domestic cats, lions, in a couple cases, can certainly at least carry it, even though it doesn't seem to affect them. But as far as how transmissible it is, the gorillas are a little bit different. If they're primates, they're more closely related to humans than felines would be. I will say, for the record, nobody has ever conclusively proven zoonotic transmission of COVID-19, but I'm sure that they're certainly keeping it in mind.
Well, apparently they got it from a keeper, so if it went one way.
We actually, this is, there's other parallels too. Like, for example, there's certain strains of that are related to tuberculosis can actually be transmitted from humans to the livestock they care for, but not necessarily the other direction, or at least not through respiratory means. If you drink contaminated milk, you can get TB that way, which is one reason why I always tell people knock off the raw milk. That's, lightning only needs to strike you once. But as far as how effectively that a cow infected with it can spread to humans, assuming you're not using any animal products from them, it doesn't seem to happen that way. It goes the other direction. So the fact that it can occur one way does not necessarily mean it happens the other direction.
Good point. Kevin asks that he hears San Diego County has received nearly 500,000 doses compared to our 204,000, even though their population is only a little bit bigger than Riverside County. Any ideas why that might be?
Yeah, I think, so Kevin, when they are looking at allocation of doses, it's not just strictly population based. They're looking at the population in the eligible categories. And so in phase 1A, San Diego County has a higher number of healthcare providers than Riverside County does. Interestingly, San Diego feels like their allocation is going to go down when the state shifts that eligible population to be the 65 and older, because they don't have as much of an aging population as we do or some other counties. So that's the reason for the difference in the allocations.
Interesting. Okay, thanks.
Thank you. And someone asked about the math. 800,000 in the current stage are to be vaccinated, and we're getting 23,000 a week, about 100,000 a month. Are we really talking about 8 months to go before we can move down to the next stage? And other people getting it?
So please, I hope not. But I mean, if our allocation were to remain stable, yeah, the math, I wish that I could fudge it, but I can't, right? We're looking at something like 37 weeks, I think is what we calculated. However, as I mentioned just briefly, we are really counting on the fact that our allocation will start to go up with this recent purchase and as new candidates for vaccine come on the market. So, the president has said, and Dr. Fauci have said that they would like to have the majority of the population vaccinated by end of summer. That will require a big increase in vaccine allocation and distribution, but I think that would be a good thing. And all of us are really hoping that happens.
Yeah. Well, it's a related question to that, so hopefully it will increase. Scott Jones writes that his sister is a feline veterinarian and has had several cats that likely died from COVID. She said she's never seen anything like it in the 20 years she's been in practice.
Wow. Speaking as the son of a vet and then having my own particular flea bag who's running around here somewhere, I mean, it certainly is plausible, but there's just not enough data to say. The best I can say, like I guess we're primarily looking at it from the animal to human transmission, and at least that does not appear to be confirmed. Besides the fact there's plenty of other places you can get it right now anyway.
So somebody else asks if HMOs are included in the 23,000 doses per week that are being allocated to Riverside County. And so should they wait for their HMO to notify them? It's places like Kaiser or Desert Oasis or DAP. Some of them are contacting people directly.
Yeah, so that's a bit of a mixed bag. And Dr. Kaiser, again, feel free to chime in. But so the state has what are called multi-county entities. So Kaisers, tenants, those entities that are in multiple counties, as the name would imply, get a separate allocation from the counties. And they are free to allocate to their facilities as they see fit based on epidemiology of what they're seeing in their clientele. They also are supposed to be outreaching to non-members. We as a county don't have good visibility into the amount of vaccine that's coming into the MCEs in our county. And it is not counted in the 23,000. The FQHCs like Desert AIDS Project and Borrego, those types of places are included in our 23,000. So it's the multi-county entities are not, everybody else is.
Okay. Thank you. Someone asks, if you're on a list with your provider, should you trust that you will be called, or should they look around for a county site or one of the pharmacies that are distributing vaccines?
My best advice is take it as fast as you can find a place that will give it to you.
And somebody asks what your thoughts are on the state's pilot website, myturn.ca.gov, for scheduling vaccines. Do you think that Riverside County may have this as an option in the future?
Yes, so we are looking, currently evaluating both MyTurn and then also our own electronic health record that we use, which is Epic. So we will definitely be changing to one or the other within the next probably 2 weeks, just simply because the current system that we're using, that is a state system as well, is obviously not performing at a level that we would like it to perform. It's very cumbersome. It's very challenging to register. You have to put all your information in and then find out that a vaccine appointment is not available. And then you start all over again when you try for another one. So there are a lot of issues with the current system. And so we want to move onto a platform that is going to be much more user-friendly for the customers or the end users. So The team is actually evaluating that right now. We just saw a demo on My Turn. It does have a lot of functionality. But the nice thing about using our own system or Epic is that we would have ultimate control over that and be able to customize it as we want, whereas My Turn is still a state system. And so changes to it would have to be done on a consensus basis with our other partners across the state. So more to come on that in the next probably 10 days or so.
Thank you for that. So someone else asks, how do I go about raising my hand about comorbidities? I'm 75, have heart disease, 2 open heart surgeries, COPD and pneumonia 4 times, and still have not been vaccinated. What are my best options?
So this gentleman, Mr. O'Connell, actually direct messaged me, and I answered him that way, but I'll go ahead and do it here. You would probably qualify on age alone based on what the state announces later this week. Now, I'm going based on the advanced information I have. We don't know if this is actually what the state is going to do. They are still working on it, but that is my guess. For the record, I do agree that you have significant comorbidities. And again, this is what I was alluding to earlier, HIV not being the only one that may put people potentially at risk. And we are definitely making the point to the state for patients in your situation. This will certainly apply to other individuals who may have other disabilities which would put them at risk. And I don't think this gentleman would be in any different situation.
Thank you for that. Someone asks, do we know about if a vaccine can prevent you getting infected and transmitting to others? And he'd like to have an explanation about how vaccination slows the spread of the virus and the pandemic.
Primarily, the vaccine's way of slowing the spread is by hopefully preventing you from getting it in the first place. And that means that there's enough people where it just can't spread to, and eventually it'll die off once you get to whatever that level of herd immunity happens to be for the dominant strain. That's why we are paying attention to strains, because they do have a difference in what we call their basic reproductive rate, which is how quickly they move through a population. And that number, there's a little bit of math there, and I won't bore you with it, but the long and short is that's the number you use to compute how much of a percentage of your population needs to be immunized. You factor both in that rate, you factor in how effective the vaccine is, and then you get a number at the end of the number of population that you need to have dealt with. Mm-hmm. We believe that based on that the vaccines probably do diminish your risk of transmitting it also. We believe this based on the fact that if you are less sick, you have lower viral loads. The people who have been in the most trouble and ended up hospitalized with the most serious disease are those who have the most virus within them. And secondarily, the ones who also, these are the ones who also are likely breeding additional strains, because the way that the virus mutations accumulate is by rapid reproduction. And somebody who is acutely ill and you have lots of virus reproducing in lots of different places, you have lots of different opportunities to generate these alternate strains, and one of them will get selected for, and that's where these things emerge from. Thus, we believe that since you are less ill, you have less virus on board, and therefore you are less able to transmit it. However, what we don't know is exactly how good that is. Some information from Israeli studies, and Israel is the country which has the most experience with vaccination. They are far and away doing the best job of any country, at least right now. It appears that from their preliminary data, there's a reduction in transmission of about 60%, which is pretty good. But that still means that you're still able to transmit at about 40% efficiency. So you are still in some ways able to transmit it. And if somebody's around who happens to be more vulnerable and it takes only a smaller snootful of vaccine for them to actually get ill, then that can still be potentially concerning. That's why that even if you are still immunized, at least we still get to the point where we have sufficient immunity within the population, we would still probably follow quarantine guidelines. We still want people to be masked. We still want you to social distance, simply because we do not know right now how less effective a transmitter you are having received the vaccine. And even though your likelihood of having severe illness is less, you may still be able to pass it on to somebody who's unimmunized who may have a worse reaction, such as virtually everybody listening to this call.
Mm-hmm. And then, certainly the idea of viral load is very familiar to those of us with HIV. So
I'll bet.
Your concept. So thank you for that. And then a corollary to that is, do we know how long what the durability of the protection is from these vaccines? Because they're brand new.
No, we don't. We believe that they're pretty good. But no, we don't know that. And again, that's why the strain question comes into play, because if they're very keyed, your immune system is relatively fuzzy and it can adapt to certain changes, and enough cross-reactivity exists that some of these strains are clinically irrelevant. But there may be enough of a change that your immune system fails to recognize it anymore. So that also plays into it. We believe that it's durable, but there's entirely the possibility we may be looking at booster shots in the future, either because the strain changed and we now need to make certain running changes to the vaccine to make that possible, or it turns out that, like the flu shot, it works pretty well for one particular strain, but not for another, or it wears off, or any number of factors that are involved. The long and short of it is we only have some limited data on how long it lasts. All that we know is that in the short term, though, it appears to be pretty good.
Thank you. Someone asked, how will the county notify people regarding the second dose if they got their first dose at the county site?
So depending on what information was provided during registration for the first dose, people will either receive an email or a text message saying that they are due for their second dose and that they can go online and sign up, or call 211 and get appointments. And again, we are doing clinics that are just for second doses. So hopefully that will make it easier for people to get appointments.
Great, thank you. And someone asked, what role is Blue Shield playing in the vaccine distribution? And do you anticipate that affecting the county's current plans?
Yeah, so that's a great question. So the state announced the role, or the utilization of Blue Shield to do vaccine allocation, but there was not a lot of detail provided in terms of what that is going to look like. So what we know so far is that they will take over the allocation and distribution of vaccines. And so they are going to be looking at a variety of different things. It is going to be very much a pay for performance and an incentivized vaccination scheme. So providers that are vaccinating at high rates will be incentivized, but they also are supposed to be including equity in that incentive package. So providers who work in underserved communities, providers who do mobile teams, providers who do homebound individuals, provide translation services. There also is supposed to be some level of payment for outreach to people to get them vaccinated. So the contract is still being developed. Lots of details still need to be ironed out. I think that universally, those of us in public health are a little bit concerned, just because we don't want speed to be the main objective and not consider things like equity and disproportionately impacted populations. So we're hopeful that we will get to have a very close working relationship with Blue Shield. Also the local health department and the local community, all of you, I mean, we all know who the providers are that are doing the outreach and doing a good job reaching people. And Blue Shield may or may not have that level of knowledge. So we really hope that they are open to input from the local health department so that we can be of assistance with recommending allocations. But we just don't know. We also don't know if, as public health, we'll be able to get the same level of allocation that we have right now to be able to do mass vax clinics. So we just have more questions than answers right now. And I think that it will probably be a good 2, 3, 4 weeks before we really know what the impact will be.
Great, thank you. Someone asks, Kevin asks actually, he's unclear as to whether or not Riverside County is prioritizing second doses over first doses or vice versa, or splitting the difference. There's a lot of grumbling about this among friends and neighbors who've got their first dose.
Yeah, there's a lot of grumbling among us as well, Kevin. So I guess the best answer I can give you is it's fluid. And I know that sounds really corny, but week to week, we're looking at what our allocation is. We're looking at how many people are due for second doses. We're looking at how many people we still have to do for first doses, and trying to put the vaccine to the best use that we can. We don't have a magic formula right now in terms of we're keeping X amount for second doses. We do want to get second doses into people's arms, but we're just trying to maximize vaccine utilization at this point. I know that's not a great answer, Kevin. I'm sorry. Dr. Kaiser, anything you want to do to bail me out here?
No, I mean, I realize that part of what we're saying is trying to speak out of both sides of our mouth and at the same time, because we want to prioritize the second dose. We also want to get people immunized. Unfortunately, this is a very thin line to walk. And realistically, like everything else, this improves only when we get more vaccination in stock.
Yeah, no, fair enough. I think I'll just add that, I think one of the other things that I hear is that, the people have the impression that some of the providers are prioritizing the second dose. People get their second dose appointments as soon as they get the first dose. And so the contrast between that and what has happened at the public health clinics is really, it's in the air.
Duly noted.
And there's a question about recommendations for pause folks on the use of monoclonal antibodies if you were in the 10-day early period of infection. Can you speak to treatment issues?
You could certainly do that. I don't see any reason why you wouldn't be able to use a monoclonal antibody treatment in an HIV positive individual as opposed to anyone else. The flip side of that coin is, remember that most of the monoclonal antibodies are under EUA. We don't have clear evidence that they work, and they may only work in certain circumstances. For example, bamlanivimab, which is one of the least pronounceable medications on the market, is really only useful outside of the hospital, yet you still have to have it infused through IV, which has limited its utility. But nevertheless, it may prevent you from having a worse outcome in the hospital, may allow you to hopefully ride it out at home, which is itself a good thing, not only from the hospital's view, but probably yours as well. Long and short of it is, if that's available to you and they think that it would benefit you based on the situation that you're in, I don't see any reason why not.
Great.
Yeah, thank you for pointing that out. Emergency use authorization. Sorry, I got a little bit jargon.
Yeah, no worries. We all get caught up in our acronyms, so that's why I'm here to translate whenever needed. Someone asked, similar to HIV eradication versus total cure, what goal is being considered successful in the case of COVID?
Really, what this question is asking is, when is this going to be over? That's actually the bigger version of this question. So let's draw a couple of comparison points. Let's look at a country like, say, New Zealand, which has virtually no community. In fact, I won't say virtually, has no community COVID. The only COVID-19 cases that are occurring in New Zealand are ones where they occur in what they call MQI, or managed quarantine and isolation. They had one community case where somebody got infected, and they jumped on it like a pile of bricks, and everything tamped down. They don't have any more cases. Australia restored their travel bubble with them afterwards. So the real question for New Zealand is, when do you open back up? At what level of virus are you willing to tolerate? It's actually an easier question for us to answer in the United States, because our answer to the question is anything but this. So any reduction in there is something that we're willing to put up with. I think that the question is actually easier to answer in the United States than anywhere else, because once we beat it back down to a level where we don't require the contact tracing army and the case investigation army and the lab testing requirements and everything necessary, I think that's when you consider it's beaten down to a point where we can manage it with our usual public health infrastructure. That's really the question that needs to get back to. A lot of people who have complained about the county and later the state reaction to this has said, well, we don't lock down our economy for the flu. That's correct. But we also have a flu shot. The flu is much less dangerous than COVID-19. The flu is also less communicable than COVID-19. So you really want to get to a point where you can manage it with the tools that you already have in the toolbox and go from there. That may well mean that if we have a situation in the future where COVID-19 does evolve into some different type of coronavirus. Remember that there's several that circulate in our population to this day and are generally causes of the common cold. It may entirely be that its natural history is to become more widespread and yet less dangerous, and then you stop worrying about it. The real question is actually for a country like New Zealand is, at what point do you open it up and then just deal with whatever cases you happen to import in? They've actually done such a good job that now they're a victim of their own success, because any case that they get in there is clearly worse than where they are now. Whereas we in the United States, any reduction in our case numbers are clearly better than the situation we find ourselves in. I think that once we get to the point where we can deal with this as episodic outbreaks of limited scope in certain areas, because the majority of the population is vaccinated, We either have a way of dealing with it through booster shots, or the vaccine has turned out to be robust against it. And once we get to that point, then I think that that's the goal that we're going to get to. I do not believe that COVID-19 can be meaningfully eradicated, certainly not globally. I think what we want to look for is a point where it's containable. For a period of time, we could do that. We're obviously long since that stage, and I think that what we ultimately want to see with this vaccine is that we get back to a position where we're able to meaningfully stamp it out when it happens to flare up in an area. Kim, do you have anything to add to that?
I think you summarized that beautifully. Thanks, Dr. Kaiser.
Thank you. And just so people know, there are 2 places in the Valley that are doing clinical trials for COVID treatments. One is Palm Tree Clinical, and I put both of those in the chat with links to them. And they are doing ambulatory studies, so people who are not hospitalized, you can walk in, participate in the trials. And Eisenhower is doing both ambulatory, walk-in treatments, as well as people who are hospitalized. So check those out if you're interested, or if you know someone who is has tested positive for COVID, might be interested in participating in those. One other question is lots of talk about medical people burning out and being subject to various mental issues. Seeing as how medical personnel are crucial to what happens going forward, is this situation getting any better? And my follow-up question is, if not, what are we doing about it?
Yes, there is a lot of concern about that. And certainly from my view, I participate with the Riverside County Medical Association, which is the organized medicine branch of the AMA and CMA, which covers Riverside County. And this is a regularly reported topic. And even though I'm going to talk about this primarily from a physician's point of view, obviously the same applies to our nursing staff, lab techs, our environmental staff in hospitals who have to clean up, and often the unsung heroes there as well, because they have to deal with the mess. So I'm really talking about anybody within those 4 walls. The situation is getting a bit better because hospital censuses are getting a bit lower. But I think also what really weighs on them too is you look at our death numbers today. For example, we added an additional 80 to our count. That weighs on people, is to watch folks die and slip away on you. I think today also many of you heard that Captain Tom, that centenarian in the UK, who raised millions of pounds for COVID-19, himself contracted it and passed away because he was 100, and that would have been a death sentence the day that he tested positive, unfortunately, and that's exactly what occurred. I think watching that kind of thing really weighs on people, especially, given the fact that whatever we can do to try and prevent it, I think they're frustrated to the extent that their hospitals are becoming impacted. That number is improving, but it's not only improving through discharges, it's also improving through deaths, unfortunately. I don't want my hospitals to be disimpacted by people dying as opposed to going home. We are working on ways to get additional help for the hospitals that need it. Both at the federal and state level have brought in additional reinforcements. But I think the biggest and most important thing they want is just to stop seeing their hospitals and medical offices overrun with COVID positive patients. They require a lot more care. You have to maintain you have to maintain significant infection precautions. I mean, we're doing that anyway, but particularly when they're positive. I think that more than anything else is what's necessary to deal with the burnout. I think that there will be a real impact on our medical capacity, because a lot of people just plain frazzled them over how much work they've had to do and the long hours that they've had to endure. I think, we talk about the impact of COVID-19 on our public health system, and that's profound, but I think there's also going to be a major impact that's not only right now, but residual on our medical care system as well. And we're only now getting to grips with how significant that is.
I think I would just add, if I may, we have been talking with CEOs from hospitals around the county, and what I hear from a number of them, and specifically I have knowledge of what's happening at our county hospital, behavioral health, the hospital is bringing in behavioral health providers to do that kind of decompression, debriefing with the medical providers at the end of their shifts so that they can try to help with some of those coping mechanisms. It's not a perfect system, but just one of the tools that hospitals are also trying to use. And we in public health are doing the same thing. We have a behavioral health clinician that is working with our staff because it's just, it's been a year now that we've all been at this, and dealing with, as Dr. Kaiser pointed out, all of the challenges with it, naysayers in the population when you're working, 7 days a week, and you have people saying this is a made up virus, that all gets to people after time. So really trying to be cognizant of that and make sure that people have an outlet for dealing with it.
Thank you. And speaking of healthcare workers, the media was reporting that up to 50% of healthcare workers in the county were refusing the vaccination. Is that still the case? And now how does that impact things?
So I will start. Dr. Kaiser can jump in here. So that was a quote from me that started that conversation. And that was after our first round of vaccinations at the hospital. So we delivered vaccine and they did their first clinics. And so there were a lot of reasons why that number might have been low, including people that were not on shift when they offered that first clinic, or people who were busy working and couldn't get away during the clinic time, or people who wanted to wait, I'm just going to wait a couple of weeks and make sure that nothing bad happens, right? So I think that, while it was a true statement at the time, I think that the numbers have definitely gone up. We've seen a good increase in the uptake of vaccine, and I expect over time that we'll continue to see those numbers go up. Dr. Kaiser, I don't know if you have anything you want to add to that.
Yeah, I'll just add that one of the things to keep in mind too is people's perception of the vaccines is not monolithic. Certainly, I with my medical students, I always put people into 3 buckets. You have the people who will get a vaccine because they believe in a vaccine and there's no stopping them. There's people who are not going to get a vaccine and are never going to vaccine because it's cancer causing or something. And then you have the people in the middle, which is the majority of the population. And unfortunately, or possibly fortunately, people move all over the place with that. They can be affected by what they see going on, what they hear around them. I think that as people become more familiar with the vaccine and they seem to understand it, more people around them have been vaccinated. They say, okay, they got a little bit of soreness in their arm. They might have gotten a little bit under the weather for a day, but they're good. They start seeing the benefits of it, because I've said from the beginning, this doesn't go away until there's a vaccine. The vaccine is here, and we need to embrace that. And particularly also, unfortunately, for those people who have been touched by COVID-19, which is a greater and greater segment of the population. Somebody died in the hospital, somebody kept going back into the hospital, somebody with long COVID. That's something that doesn't really get talked about much, is the impact of long COVID, especially against the background of chronic fatigue syndrome, CFS, ME, all of that. We don't have a good case definition for it, but by any measure, it's going up. So there's a substantial portion of the population that by now has some connection to COVID-19 and understands the deleterious effects of it. And because of that, I think that is going to change people's perception of the vaccine to realizing, this is the way we get out of this. No, I wasn't so sure about it before, but now I think I'd like another bite at the apple. So I think it's important to just keep in mind that for many people, it's going to be a process.
Thank you. That's encouraging to hear, because that number really got around, and it'd be great if the media could follow up and say these are the latest statistics, so people have a little more confidence. Because
well, even to add on to that, our PIO, she's up in arms about this, because she actually did do a market study. We did this a couple months ago, which determined 73% of county residents are either very likely or somewhat likely to receive the vaccine. Now, again, yeah, thank you, Public Information Officer. Yeah, yes, the people in the somewhat category is still not a lock for getting it, but most people seem to have a favorable predisposition towards the vaccine, and I think that number will only get larger.
Thank you. That's encouraging to hear. Any other questions for Dr. Kaiser or Kim Saruwatari?
Yes, I have one. I read today that only 38% of nursing home employees were taking the vaccine, and that's obviously a very recent number. Is that either of your understanding, or, and if so, why would that be?
So the nursing home program or skilled nursing facilities and long-term care facilities are covered under a CDC pharmacy partnership. And so the CDC is contracted with CVS and Walgreens to administer vaccine in those locations. And admittedly, they've been very slow to roll out the program. And so it is taking quite a while to get first dose to make it through our 58 skilled nursing facilities. And so I'm not sure if that is the reason for the low percentage, or if I have not heard that the uptake by staff when offered is only 38%. But is that what you saw when you read the piece of information?
Right, it was that 38% accepted the vaccine and the remainder did not.
Interesting. I haven't heard that data. Dr. Kaiser, have you?
No, he's reporting it accurately. That is what the article said. It was, I believe it was in the Associated Press. So yeah, I don't have a good explanation for you on that one, Mr. Hahn. And I think that it is a shame because that population certainly are the ones who are greatly at risk and the ones that we have seen some of the highest mortality when it happens to get in one of those settings. Unfortunately, I think there's also a lot of misinformation that circulates in those settings. Those settings also tend to be particularly underfunded. That's one of the reasons you may recall when we had to evacuate that nursing home, which seems like an eternity ago, but nevertheless, because only one person showed up for work on a shift and you've got all these vulnerable people there. I think that we have a lot of work to do with making sure that they understand this, making sure their administration understands the importance of getting those folks in and getting it done. But again, like anybody else, I think that 38% is a process. Right now, for the majority of them, they may be looking at it simply as, I don't see how this is going to protect me. Why should I bother? But again, unfortunately, as a greater portion of the population is touched by COVID-19, I expect this to shift as well. We do have a regular team that goes out and meets with our skilled nursing facilities and other long-term care facilities as well. And I know that they are also talking about this with them. That 38%, I don't know if that's true for Riverside County, but if it's at all generalizable, we certainly want to make sure that that attitude does not become entrenched.
Yeah, thank you for that. And speaking of captive populations, can you speak to the situation in the county's correctional facilities and how bad it is there, and if there's a lot of kind of cross infection between the facilities and their surrounding communities?
I'm simply, there's obviously certain delicacies involved in this. I will, and I don't want to speak for the correctional health system. I will say that the medical director for the jails had tried to jump very early in with a robust system of testing. To my understanding, that is what they are doing. They have had positive cases in there, which they have isolated out. We've been involved in a few of those. So without walking into the politics, which I know some of you in the desert are aware of some of the recent exchanges which have occurred on social media, I'm going to very delicately tiptoe around those and simply say that this, at least in terms of what Correctional Health Services is doing, they regard COVID-19 as a priority and they're trying to deal with it.
And do they have their own vaccine supply, or does that come through the county, or how does that work?
For the county jails, this comes through us. Kim is nodding. For the state facilities, they have their own separate allot.
Thank you. And someone asked if there's been an attempt to enlist clergy to recommend vaccination to their congregations.
Yeah, so we have actually a very large undertaking out in the Eastern Coachella Valley in particular. We've contracted with the Archdiocese of Riverside and San Bernardino County, and they have been just a phenomenal partner in terms of doing outreach to their congregation. They have been hosting testing events. They've hosted one vaccination clinic, and they're willing to do more. They put information in their bulletins. They've done videos to send out to their congregation. They've been very, very supportive. And we actually have seen a dramatic increase in our number of people getting tested after that partnership was put in place. So they're very influential in that area of the county. So that was kind of where we started, and now starting to move out to other areas of the county. So we haven't made a lot of headway into other denominations at this point, but we have partnered with a few churches to host events, and we'll continue to do that as we roll out more vaccine clinics.
Okay, thank you. Yeah, I think engaging the faith-based community is going to go a long ways to addressing the medical mistrust in many marginalized communities. Someone asks about their brother who tested positive 4 or 5 weeks ago, but had a very mild case and recovered. However, the brain fog hung on for a while. Can you speak to what that is? That's, I think, the long COVID you've been referring to, a part of it.
Right. The interesting thing about COVID-19 is the wide number of organ systems which can actually affect. For example, and this is, if I may mention a particularly pernicious myth that circulated for around for a while. There was a assertion made for the longest period that says only 6% of people who died of COVID-19 died of it. The rest of them died with it. This actually was a fundamental misunderstanding of how death statistics are actually reported for COVID-19. The standard way that they should be reported is you give a cause of death, which in most cases is what we call acute respiratory distress syndrome, or ARDS, and then you say secondary to COVID-19. The reason you do this is so that we actually understand how it kills people. Because if you simply write COVID-19, I have no information into the pathophysiology. By doing this, I understand that it is primarily affecting people respiratorily, but there have been other situations where that has had cardiac manifestations, vascular manifestations, so on. Really, all that 6% says, it's not that 6% of people who died of COVID died actually of COVID. It just says 6% of doctors are lazy. That's really all it says. Now, to bring this back to the brain fog question, the reason I took that little detail was to point out the variety of ways in which COVID-19 can affect you. As far as the brain fog question, we don't know where that comes from, but there certainly is an association with it. And as you point out, this can even occur in people with relatively mild disease. One thing that hasn't been mentioned about the hospitalization question is how many people leave the hospital and then end up bouncing back for some other reason, often some longer term complication, which has been a substantial minority of patients. We don't know who is most likely to experience it from it. And because there's so little understanding, or what we call a case definition, of what exactly constitutes long COVID or any of the other symptoms associated with it, and the mental fog being one of the most prominent of those symptoms, we don't really know either why that's occurring, how long it's likely to last, or what to actually do about it. The best thing that I can suggest on this is we do believe that it is linked to it, but we don't have a clear understanding of why it actually occurs. I would say that if it seems to be lasting for an extended period, and extended period could be, in some cases I've heard it going up to a couple months. If it seems to be getting much up to that or beyond it, I think that may be worth a discussion with the neurologist just to make sure you're not missing something else.
Great, thank you very much. Well, we're at over an hour now, so any other final questions that anyone has? If not, I'd like to thank Dr. Kaiser and Kim Saruwatari
Yes.
for joining us.
Definitely. Thank you so much.
Yeah, thank you.
Thank you for having us.
We know how incredibly busy you are and the pressure you're under, so we really appreciate you taking the time.
Anytime.
Our pleasure.
Thank you so much.
Yes. Take care. Good
Oh,
night.
thank you.
Stay safe, everyone.
So we have one more guest speaker. And as you know, originally this program was going to be about HIV cure research, but because everything is COVID right now, we wanted to jump on the opportunity for Dr. Kaiser and Kim Saruwatari to join us. And we also had the pleasure of having Rayanne Moore, PhD from UCSD, here to talk about one of the studies, actually a couple of the studies I think they're going to be doing. So Rayanne, are you?
Yeah, let me share my
Okay, you should be able to share. And I will post a couple of the links that Crosby had sent.
Oh, fantastic.
For people for the YouTube video.
You would think I would be an expert at this Zoom PowerPoint at this point.
It wouldn't be a Zoom meeting without at least one glitch, right? So.
Yeah. Oh, you know what? I do need to just unplug my external monitor here.
And in the meantime, I'll put those two links in the chat.
Still looks like it might be the wrong viewing here. I'm just gonna leave them like this, if this is fine with everyone, instead of presentation view. Can you all see the screen okay?
It's kind of off to one side, so I don't know if you can move it.
Oh, it is, okay. Is that? Maybe I'll try the starting it again.
And you didn't send me a copy of it, did you? You got a couple of
Oops. No, is that better?
That's still the same. It's kind of off to one side.
All right. Let me try again here.
If that doesn't work, you can always send it to me and start talking, and I can pull it up.
Okie dokie.
Easy.
How's that?
Okay, we're good.
All right. Okay, great. Well, thank you for having me. And this is going to be an interesting talk after all the COVID stuff. You know, we are still actively doing research at UCSD and at the HIV Neurobehavioral Research Program, where I'm an investigator. So I'm going to be talking a little bit about primarily about one of the studies that we're currently enrolling for. And I'm also happy to spend some time talking about some of the adaptations we've made to our research protocols during COVID. I realize you know, it's already been a little over an hour, so people might be getting a little Zoom fatigue. So I'll go through this as quickly as I can. I also have a cold, so I apologize for the sniffles. But a little bit about me. I'm an associate professor in the psychiatry department. I'm trained as a clinical neuropsychologist. I did postdoctoral training in geriatric mental health as well as neuro-HIV. I've been with our HIV neurobehavioral research program for a long time now, actually. Yeah, I met Jeff, yeah, years and years ago. So thank you for having me. Just a couple disclosures. So before I jump into kind of the ongoing study we're recruiting for, I did want to chat or just share a little bit of information about some recently completed studies that we've done using mobile technologies. And these studies were all done pre-COVID, but I think a lot of the data obtained from these studies has helped inform, you know, our adaptations we've had to make during this COVID era. So we recently pre-COVID completed a study where people were sent home with study phones and completed some active data collection, completed surveys 4 times a day on the smartphone, just about their everyday activities and mood, socialization, things like that. They also did some cognitive tests on the phones, so some tests of memory and what we call executive function, which is planning, organization, inhibition, things like that. At the same time, we gave people smartwatches, so like a Fitbit or, you know, Apple Watch. We gave them a research grade one, which wasn't as pretty or as cool, but to wear for the study duration. And we had people wear them for 24 hours a day. For this study was for 14 days, and we got sleep and physical activity from our watch data. We'd also enabled GPS tracking on the phone. So we were able to look at the GPS coordinates of kind of where people are spending their time, as well as map on what we call, excuse me, geographical information system layers of the data. So how the environment in which someone lives informs you know, some of these other different variables we're looking at. So things like, you know, is there parks nearby? Is the neighborhood walkable? What's the air quality? Access to public transportation, mean socioeconomic status of the neighborhood, all of these different types of characteristics we're able to apply to just the raw GPS data. And then for, excuse me, a subset of people, we also had them install a virtual keyboard on their personal smartphone, where we collect data on how people type. So not what you type, but more how you type it, use of backspace, autocorrect, excuse me, error rate, all of those kinds of things. And by combining all of this kind of rich, both active and passive data, I should have mentioned the study was done in over 100 persons aged 50 to 74, and we had people with and without HIV in the study. With this really rich data, we were really able to just examine all kinds of interesting questions. And we've published several papers now from this data, which I've sent blurbs to the HNRP to have posted on the website. I looked earlier today and they're not up there yet, but hopefully they'll be up there soon. One example of something interesting that we found is that by using both the survey data and the mobile list learning data, we found that if people reported completing a cognitively stimulating activity earlier in the day, so if they reported they were doing something such as reading or working or using the computer, not for social media, we didn't count that as a cognitively stimulating activity, engaging with others, anything that would be cognitively stimulating, completing that earlier in the day, they actually performed better on a cognitive task later in the day. So that was one really interesting finding that a paper we recently had published. And another paper that one of the graduate students led that was pretty interesting as we looked at the relationship between the GPS coordinates of just, were people at home or not at home? And again, all this data was collected pre-COVID. And we looked at the relationships with that GPS data with how they responded to some of the survey questions in terms of socialization activities they're reporting and happiness and pain. And we found that the more time people spent at home, the lower their happiness, and the more we found self-reported pain. But there was a buffering effect for social interactions. So that relationship between lower happiness and more time spent at home went away if people were engaged in more social interactions. And one thing encouraging is that, the way we asked about social interactions wasn't, if it didn't have to be in person. So while we're not able to tease apart how many of those interactions were in person versus were texting interactions or on Zoom or on the phone, we do think that kind of any socialization really does have a good effect for mood, which has been very relevant, of course, now that we're all stuck at home all the time still. But I'd be happy to share any of the papers, and we're continuing to examine the data. We currently have one we're working on where we're looking at the relationship between the physical activity data we got from the watch, as well as sleep and the cognitive test performance in everyday life. And we are finding some nice relationships there in terms of some real-time relationships between more physical activity is related to better cognitive abilities that same day. So there's, I have this ongoing study that we're currently enrolling for, and we have been seeing participants. We were shut down from March until August of 2020, and we were able to kind of get back up and running in August, largely due to the fact that one, we were able to shift a lot of our research activities to this Zoom format, but also at the HIV Neurobehavioral Research Program, which is located in the Hillcrest campus of UC San Diego. We actually have a negative pressure room within our lab, which has just 2 rooms next to each other. One room has just a big window that people can talk through the rooms, but there's no social interaction or touching in between. So for this study, and all other ongoing studies now at the HNRP. And when we have people come in, the research participant is in one of those rooms and the testing staff is in the other room. And we've had no, knock on wood, COVID exposures.
Just to interrupt, wasn't that room originally created so they could do cannabis studies?
It is, yeah, it was. Yeah. And there's some cannabis studies still ongoing as well. So,
Came in handy.
yeah, we're so fortunate because, you know, most other labs don't have that kind of setup. It has limited our ability of how many participants we can see, because we are limited to only seeing a couple people a day versus in the past we were seeing significantly more than that. But we have made great strides in transitioning almost, you know, everything that we can to a virtual format. So this study is a multi-site study. It's between us at UCSD as well as Emory University. And I just wanted to show this slide because it shows the wide-ranging expertise that is ongoing in this study. We have investigators from our Alzheimer's Disease Research Center, as well as our psychiatry department, as well as collaborator who's an audiologist at San Diego State, and there are audiology visits associated with the study, which I'll talk about, but I think that's a nice value add because we're able to provide some kind of feedback on hearing to folks. They also have a great COVID safe setup over at that audiology clinic. And then a similar kind of infrastructure at Emory, as well as we've partnered with the Georgia Tech Research Institute to do all the virtual reality programming. And just to give you a little bit of background of this study, so kind of the main aims are to see if we can use this virtual reality self-assessment tool as a way to, one, screen for cognitive changes over time. So see if it could be a self-administered kind of repeatable screening tool. And to really see if we can try to tease apart the brain changes that occur from normal aging versus HIV-associated neurocognitive disorders versus someone who may be on the Alzheimer's disease trajectory, which is tricky to do. It's tricky to tease apart some of these trajectories at times. So that is a little bit of, you know, our aims. And, you know, we're enrolling people 60 and older as persons with HIV are now, you know, in that age range where Alzheimer's disease is something, you know, to think about. And Alzheimer's disease is a neurodegenerative disorder that impacts multiple areas of our brain function. And the outward symptoms of Alzheimer's disease are usually don't occur until after the disease has already been kind of, you know, going on for a bit in the brain. And they can actually be really hard to identify among the person and even among family members. It can really be hard to identify early on, but it's important to be diagnosed early, you know, if someone is on the Alzheimer's disease trajectory, because the earlier the intervention or earlier the diagnosis, the earlier someone could get on, you know, a medication that could help really slow the progression of the disease and lead to longer quality of life. And also more time for life planning and really just better quality of life overall. So this chart just shows, I have all your lovely faces blocking my graph here. I'm going to move you there. Kind of neurocognitive performance. So lower is worse, higher is better neurocognitive performance. And this is over time. So in normal aging, we see some decline in cognition over time that is to be expected as we age. The number one domain that is usually impacted with aging is processing speed. So, you know, as we get older, we are slower to process information. I'm screwed because I've always had really slow processing speed, but it is what it is. Wisdom, though, and positive psychological traits, just as an antidote, increase across the lifespan. So we're a little slower to think about things, but our thoughts are going to be wiser and more optimistic and more resilient in focus. Then there are a sub portion of persons with HIV who kind of meet this definition of what we call a HAND profile, and this is HIV-associated neurocognitive disorders. And it's just a minor, what we call mild neurocognitive impairment. So minor decreases in cognition that, you know, the key is it's not going to progress. So it's pretty much going to stay stable. There may be a little waxing and waning in it, but it's not going to progress. It's not a neurodegenerative process. Whereas conversely, what we call amnestic mild cognitive impairment, which is a known precursor to Alzheimer's disease, actually does progress and decline over time. And eventually, you know, a majority of people who have an amnestic mild cognitive impairment diagnosis are likely to develop Alzheimer's disease at some point in the future. So teasing apart these two trajectories is, you know, a key focus of HIV research right now, and something that the National Institute on Aging has invested a lot of money in helping us try to figure out how to do. Oops, did I skip a slide? No. So, excuse me. Yes, as I mentioned, we've developed this virtual reality screen. Oh, Jeff, you muted me for a second.
We have about 5 minutes left, by the way.
Okay, I'm almost done. A virtual reality tool to briefly assess for cognition. It also includes a way to assess balance because balance changes are also, you know, associated with risk for Alzheimer's disease. And it's a non-postural seated balance test. So you're wearing the device and you just have to move your head in different ways based on what you see. And there's no risk for falling. So people are doing it seated and it's safe. And we're hoping that, you know, these virtual reality tests could really be helpful in the clinic because it could reduce, you know, having to come in for lengthy, and if any of you have participated in our neurocognitive exams, you know that they are very lengthy. Cognitive testing is something that could just be done at home or in the waiting room of a clinic, less expensive, much briefer, and could be done repeatedly. So we can, you know, really monitor cognitive changes more frequently over time. So what's involved is, I just mentioned these, so I'll move on. We did an original study prior to the funding for this study in persons with HIV. 39 persons with HIV completed our virtual reality tool. And we did find validation that it was able to differentiate persons with HAND from persons, oh my, sorry, I had a pop up on my computer here, from persons without HAND. So what this study looks like is people would complete a full visit, and you can see up here on the right-hand side what that full visit entails. And entails cognitive testing, the virtual reality assessment, a medical interview, and a blood draw, as well as the hearing test. These, you know, we're doing them generally in 2 days, but if someone's coming from Palm Springs or elsewhere, definitely we'll do them in 1 day. The full visit now has been broken down into a couple different visits. So there's only no more than 1 hour actually in our lab for COVID. And then the rest of it is done virtually. And that can be done in one visit or broken into a couple visits based on, you know, participants' preferences. And then after 6 months, people come back and do just the VR testing portion again. And then at 1 year is a repeat of the full visit and the hearing test, 18 months VR testing only, and then 24 months full visit plus the hearing test. And here are just some interesting things we're hoping we can learn from with the virtual reality. I already mentioned a lot of these. Excuse me. So I'm going to just move on. Study participation, we are enrolling people 60 and older. Again, it does require some in-person with HNRP at this point, but a lot of it is remote. You know, we can provide some feedback on the audiology testing, which is nice, and that's something new to the HRP that other studies haven't done in the past. And we do provide compensation for transportation. So that's something we're able to do. Unfortunately, we're only enrolling people who are English speaking at this point in the study. And those are all the slides I had. I'm happy to take questions. This is our whole team at the HNRP. This picture was taken actually Christmas 2019. So this is kind of the last time we were all together. And I have not seen hardly any of these people really in person since then. But we have a big team and a lot of people dedicated to the cause and you know, are always looking for participants. So thank you for your time.
Great, thank you, Dr. Moore.
Yeah.
So any questions for Dr. Moore about the information she presented of the study?
Oh, I see Jeff. Dr. Torrey is our investigator, our audiologist.
Yes.
Yes, that's who is our audiologist on the team. Yep.
Yeah, and he presented done some work with Michael Planky for, I think it was for the MAC study, and presented on their data 2 or 3 years ago for Positive Life.
Yeah, he's fantastic.
Great. Any questions or comments? If not, thank you so much for joining us. Go ahead and put your, I put the, let me put your phone number in there. Is it 543-2000?
There's my email, and then let me get the phone number.
Okay, yeah, keep them both in. And if people have questions, they can always contact me. I think I had their number memorized by now.
Yeah, thank you. Yeah, and if you know of anyone who may be interested, you know, we're very behind in our enrollment due to COVID. So.
Good. Well, thank you for
Yeah,
you know, providing transportation and making it available to people in the desert. Are you reaching out to people in LA at all, or?
not at this point.
Okay. Yeah, let us know if you want to.
Okay, thank you. Yeah, I might follow up with you on that, Jeff. Thank you.
Great. Well, thank you again, and thank you all for joining. Hope you found it useful. Sorry for the last minute change, but you know, with COVID, we thought that once Dr. Kaiser and Kim were available, that we should bring them on to address the vaccine rollout, because that's top of mind for all of us these days. So next month will be the CURE program with Paula Cannon from USC and Sean Zaya from City of Hope. And then April will be Andrew Alder doing his HIV and the Law annual update for us. So thank you all for joining, and we'll see you again.
Thank you for the presentation. Appreciate it.
Great. Thank you all.
Bye.
Be well and be safe.
All right.